Assalamualaikum dear doctors. In this video I am discussing Addison's disease full, the history, management, everything. So the Addison's disease history, commonly the scenario are come on the exam. First scenario one, that child with vomiting and hyperpigmentation or as a part of panhypopituitarism craniopharyngioma. Number two scenario, it comes as a diabetic child presented with recurrent hypoglycemia despite good control. That is one of the cause of Addison's disease. Number three scenarios that can be present like child with hypothyroidism and after starting levothyroxine developed fainting attacks. And number four scenario, Addison's disease comes as a child with mood change, behavioral neurological symptoms and abdominal pain. Now I am telling how can we take the history of Addison's disease. So introduction is similar. Now we are analyzing history of presenting illness, complaints analysis plus systemic review. So now analyzing, like we ask the onset, when it started, the course and duration, how long the child is suffering this problem, and is there any triggering factor you think that increase and any relieving factor, altogether we'll ask. Then we ask the chief complaint associated with any fainting. If fainting, that special character, specific posture before, during and after, how abated, admitted or not. Then if there is chief complaints vomiting, we discuss vomiting like at any specific time related to food, this vomiting, color of the vomit, content, blood, dehydration, every time treated in hospital with IV fluids or not, we ask. Then if diarrhea presentation, then we ask the diarrhea features like amount, frequency, color, odor, blood mucus or not, undigested food particles present or not, and signs of fluid depletions and admitted or not. Then weight loss if mentioned, then we ask about appetite losses, evidence growth chart, or clothes become looser. Then we can exclude the weight loss. Then we go the systemic. First, generally we ask general any fever, fatigue, depressed activity and sleepiness present or not, we will rule out. Other concern like we ask that dysmorphic features, any chronic disease, especially any autoimmune disease present or not. Then we go the DIT we ask the tummy size, tummy pain, poo, if not the complaints. So poo is increased in diabetes mellitus, we know that. Oral and anal source, tongue and mouth pigmentations, present or not, will exclude. Nutrition will ask the number of the meals, content in each meal and salt craving. Remember, salt craving nutritional history presents on Addison's disease. Then CNS, we ask like there is any sign of increased intracranial pressures. In secondary adrenal insufficiency, is there any weakness, fits, bugs, trauma, hemorrhage, shunt, unusual behavior, unusual movement, depression, loss of interest to something was enjoyable before in adrenal leukodystrophy. Concern about any vision or hearing, we'll ask. Then CVS, we will ask any heart racing, awareness of the heartbeat, blood pressure, fainting when standing up from sitting, postural hypotension present or not. So that we ask that fainting when standing up from sitting or any dizziness when sitting, we will ask. Then chest we will rule out. We ask that in any recurrent bugs infection, noisy breathing, chest sounds, chronic cough, sputum, night sweating. Urinary we ask the P color, pain, amount, and if more at night than before, color changes or concern about private parts, any pigmentation or unusual shape present or not. Then endocrine we ask the thyroid causing salt crisis, numbness, blood sugar. From endocrine we also ask the heat or cold intolerance, any lump on the neck or any other parts of the body, we will ask. Musculoskeletal system, we will ask any skin spot, bruise, vitiligo, hyperpigmentation in scars, sun exposed area. This is very important, hyperpigmentation in the scars or sun exposed area. Or we can ask like before you were fair, now you are going dark, darkness increase on your skin, that we can ask. This is important finding. Swollen glands, lumps, bone pain, joint swelling, hair loss, abnormal hair distribution, nail change. Then hematology, we will ask pallor, bruising, bleeding and recurrent bug. Go for the past history of Addison's disease. So 5T, we know that 5T is trauma, traveling, any transfusion, treatment and any team involved or not. IOA, investigation, onset and admission in previously. Plus exposure to radiation, bug in the brain, travel to areas where tuberculosis is endemic or contact with a diseased person. Recent any IV line, drugs intake, easy access to hospital. Puberty in details if the child on puberty age. Then perinatal history, neonatal hypoglycemia presence or not, we exclude. Development history, development adrenal leukodystrophy, growth charts. Allergy, we ask vaccination, mixed any shots and COVID vaccine. Family history of autoimmune disease, consanguinity, home modifications, old pipes and old pains. Social and psychological history will take, and school, the attendance, absence, bullying and why due to pigmentation. Now, what are the differential diagnosis of adrenal insufficiency? So, adrenal insufficiency, acute condition and chronic condition. Acute condition, there is no pigmentation. So, acute condition when developed, that is sudden stoppage of the steroids, congenital adrenal hyperplasia, trauma, severe hypotension, sepsis, that is meningococcemia. Now, chronic when pigmentation develop, chronic DD of adrenal insufficiency are autoimmune, that is Addison's disease, tuberculosis, trauma, that is pituitary or hypothalamic, intra-abdominal any surgery, pituitary or hypothalamic surgery, radiation abdominal or pituitary, and adrenoleukodystrophy. The DD of oral pigmentation. Oral pigmentation, when we find, that is Addison's disease, we find Pearce-Jackard syndrome, we find, and it is drug induced like oral contraceptive, chemotherapy, doxycycline, zidovudine. This causes oral pigmentations. What are the causes of Addison's disease? So causes of Addison's disease, it can be autoimmune, post-tuberculosis. Post-tuberculosis, the most common cause in worldwide. Infections like HIV, sepsis, adrenal hemorrhage, amyloidosis, post-surgical removal of adrenals, and adrenoleukodystrophy. The management plan. What is your management plan in Addison's disease? Then when history we take, after the discussion they will ask this management. So I will examine her carefully, vitals, blood pressure and glucose. I will assess the airway, breathing, circulation and consciousness level, that is ABC, and also Glasgow Coma scale. Obtain IV line if in shock therapy, if in pain, analgesic I will give. I will discuss with the consultant if she needs admissions. Then anthropometric measurements, plot on growth chart and check his previous measurements. I will involve my seniors and if need my consultants. I will run some tests. So also involvement of endocrinologist, involvement of psychologist, if any psychological history presents, involve the consultants, all this also management. Investigation, what investigation we do in Addison's disease? Lab we do full blood count, anemia, urea and electrolyte. There we find what are the electrolyte balance, we find low sodium and bicarbonate, high potassium and calcium in Addison's disease. Glucose also we find low, there is hypoglycemia presence. Then I also do 24-hour cortisol in urine and or early morning cortisol in blood, ACTH level, that is elevated. So we do the ACTH level. Plasmapheresis is high, aldosterone level is low. Aldosterone level is low. Antibodies against 21 hydroxylase positive in autoimmune Addison, either isolated or as part of polyendocrine. If male with neurological and behavioral issue, VLCFA will be high. Adrenoleukodystrophy XR. Now diagnostic test for Addison's disease. These are short synthetic test and long synthetic test. So short synthetic test are injection of ACTH, then measure cortisol level in blood before and after 30 minutes and after 60 minutes normally increase cortisol production. If low cortisol, so Addison. And long synthetic test, that is intramuscular injection of ACTH daily for 3 days to differentiate between primary and secondary adrenal insufficiency. First primary adrenal causes high ACTH, low cortisol, and if secondary pituitary causes, then low ACTH and cortisol levels. Note, pseudohypoaldosteronism is due to unresponsive or resistant to aldosterone at its receptors. So high renin and aldosterone levels and hypertension and hyperkalemia and hyponatremia. Others workup for other autoimmune disease, radiology, abdominal CT, ultrasound scan of adrenal gland and X-ray, calcification if tuberculosis we find. MRI brain we do, chest X-ray or CT, ECG for the effect of hyperkalemia. Annual review. What annual review we give in Addison's disease? Lab we do the full blood count, urea and electrolyte, liver function test, vitamin B12, parathyroid hormone level. Celiac screening, thyroid function, glucose and HbA1c. Review of the skin. If skin is thinning and striae, steroid toxicity and search for hyperglycemia and hypertension, steroid overdose. If pigmented skin, generalized fatigue and weakness, search for hypotension, low dose or poor compliance. Management treatment of Addison's disease. Treatment of adrenal crisis, urgent treatment with IV normal saline, glucose and hydrocortisone. So we IV normal saline give, glucose we give because there is hypoglycemia present and hydrocortisones. Long-term management with glucocorticoid and mineralocorticoid replacement. Parent and patient educations. Multidisciplinary team involved in Addison's disease are endocrinologist, dietitian, gastroenterologist, social worker and support to the family, psychological support and psychiatric if needed, liaise with the school for emergencies and for bullying. What advice we give in Addison's disease? That is important. Bracelet, medical alert bracelet or necklace. Steroid card, education to the patient and family about sick day rules and when they must double the dose, febrile illness, gastroenteritis, major trauma, surgery and endurance sport. So sick day rules we will advise them when they take the double the dose. Education about how to inject intramuscular hydrocortisone in emergency, importance of treatment and good compliance and follow-up. Now adrenal crisis. Adrenal crisis, what is the sign symptoms? The symptoms of adrenal crisis is hypotension, hypoglycemia with fainting attacks, vomiting, abdominal pain, low-grade fever. And treatment is admission, ABCD, IV, hydrocortisone, IV fluid, fluorocortisone, not in the first year, give salt instead. Antibiotics if needed. Now sick day rules. What is sick day rules? If mild, double the dose of hydrocortisone for 24 to 48 hours. If moderate, double the dose. If vomiting after 1 hour, start IM injections. If severe illness or collapse, IV hydrocortisone and call ambulance. Adrenal insufficiency treatment. So adrenal insufficiency treatment, they are telling the line, you are not understanding. 6-day rules, I told. 6-day rules is that mild stressor, that is upper respiratory infection, fever, minor surgery with local anesthesia, 2 to 3 basal for 2 to 3 days. And then mood stressor, general anesthesia, surgery, hydrocortisone 45 to 75 milligram daily. Major stressor, critical illness, hydrocortisone 150 to 200 milligram per day. This box is emergency management of pediatric adrenal crisis, intramuscular hydrocortisone dose or initial IV dose. So that is age, according to age, IM hydrocortisone dose and indication for hydrocortisone. Age is less than 1 year, we give IM hydrocortisone dose 0.25. An indication of hydrocortisone is that acute unwell and unable to get IV access. And then 1 to 5 years we give 0.5 dose, and 6 year and over we give the 100 milligram. So less than 1 year we are seeing the dose is 0.25, 1 to 5 year is 0.5 and 50 milligram, and 6 year and above is 100 milligram. And indication for hydrocortisone, that is acutely unwell and unable to get the IV access, number 1. Number 2, acutely unwell with diarrhea and vomiting and unable to tolerate oral treatment. Number 3, reduce the responsiveness or loss of consciousness. Number 4, hypoglycemic or new onset of seizure in known or suspected adrenal insufficiency. And number 5 is fracture or significant burn. Now, algorithm for the management of the patient with suspected adrenal insufficiency. So, first, clinical suspicion of adrenal insufficiency. When develop the clinical suspicion, the features are weight loss, fatigue, postural hypotension, hyperpigmentation, and hyponatremia. Then, screening or confirmation of the diagnosis. Plasma cortisol 30 to 60 minutes after 250 microgram. Then cosinotropin, IM or IV, cortisol post cosinotropin less than 500 nmol per liter. CBC, serum, sodium, potassium, creatinine, urea, and TSH. Differential diagnosis: plasma ACTH, plasma renin, and serum aldosterone. Then they divide 2 parts: primary adrenal insufficiency and secondary adrenal insufficiency. So primary adrenal insufficiency, that is high ACTH, high renin, low aldosterone. Then next, glucocorticoid plus mineralocorticoid replacement. Then adrenal autoantibodies, positive or negative. If positive, then autoimmune adrenalitis, autoimmune polyglandular syndrome APS. If negative, that is chest excess, serum 17 OHP in men, plasma very long chain fatty acid, VLCFA, and adrenal CT. Then again, the negative is if positive, then adrenal infection, tuberculosis, infiltration, example lymphoma, hemorrhage, congenital adrenal hyperplasia. If negative, then autoimmune adrenalitis, most likely diagnosis in men, consider adrenoleukodystrophy, VLCFA is increased. Now, secondary adrenal insufficiency, what we find: low normal ACTH, normal renin, and normal aldosterone. Then glucocorticoid replacement. Then MRI pituitary, positive and negative. If MRI pituitary is positive, that is hypothalamic pituitary mass lesion, and negative, then history of exogenous glucocorticoid treatment, history of head trauma, consider isolated ACTH deficiency. So this is the total about Addison's disease, how history you take and management, everything. Thank you.